Nephrology. This is the second session of a quick 8-session board review designed to allow you to prioritize areas needing further study as you progress towards the boards or as you progress in your study of nephrology. This second session is concentrated on sodium and potassium aberrations. Let's begin by discussing hyponatremia. Hyponatremia is defined as serum sodium less than 135 millimoles per liter. Serum sodium greater than 129 millimoles per liter is mild and is not considered worrisome unless there is a downward trend. Serum sodium 125 to 129 millimoles per liter is moderately low and requires proactiveness, but is generally not dangerous. Serum sodium below 125 millimoles per liter requires urgent evaluation and treatment. Besides the absolute value of the serum sodium level, symptoms are very important. If the patient is symptomatic, then the situation should be considered clinically dangerous and must be treated appropriately and emergently. Sodium is not a problem of salt. A lot of patients will come to you and they will ask you, am I not eating enough salt? Am I eating too much salt? Sodium is not a problem of salt. Sodium is a problem of water. It is a relative excess of water. Pseudohyponatremia is an abnormality of the laboratory testing apparatus and does not require treatment. Pseudohyponatremia will be discussed individually in a separate session after the 8 sessions of board review. Pseudohyponatremia typically occurs in the setting of elevated total protein and total cholesterol. Hyponatremia due to hyperglycemia is not pseudohyponatremia. It's a hypertonic condition, and hyperglycemia must be treated. So the first step in treating hyponatremia is to establish hypotonicity and exclude pseudohyponatremia, in which the serum osmolality will be normal, or hyperosmolality, such as hyperglycemia. Hypotonicity is defined as serum osmolality less than 280 milliosmoles per kilogram. Frequently, serum osmolality appears normal. This can be in the condition of acute kidney injury, chronic kidney disease, any clinical setting in which the BUN is elevated can result in a osmolality which appears normal. One must correct for elevated BUN. You should divide the BUN by 2.8 and subtract from the serum osmolality. The correct serum osmolality is usually consistent with hypotonicity. Patients who have undergone transurethral resection of the prostate, hysteroscopy, or laparoscopy have received irrigant solutions that are non-sodium solutions, such as glycine or sorbitol-containing solutions. These can cause severe hyponatremia, and serum osmolality can be very variable in these cases. Glycine and or sorbitol metabolism and urinary excretion will lead to normalization of serum sodium. Remember that the overall clinical context is usually much more important than a single electrolyte. Do not focus on an electrolyte. You must focus on the global clinical context. If possible, maintain the goal of gentle correction of serum sodium, usually 8 milliequivalent change in 24 hours. Events in the emergency room are very important. Frequently, events in the emergency room will alter the urine indices. Fluids are almost always given in the emergency room due to the urgency of the setting and lack of information at the onset. For example, if there is a condition of ADH excess, such as suspected hypovolemia, and an intervention such as intravenous fluids alters the ADH excess, meaning it suppresses the ADH, then the urine indices will change. And urinosum is frequently low because of ADH suppression from acute intervention. Let's talk about common conditions. The most common condition encountered in the clinical setting is hypotonic hypovolemic hyponatremia. Hypovolemia stimulates ADH secretion. Most hyponatremia will be due to excessive ADH secretion, and we will see that when we explore the differential in detail in the upcoming slides. Hypovolemia is no different. Hypovolemia stimulates ADH secretion, resulting in hyponatremia. Hypovolemia also indicates a decrease in total body sodium due to renal or extrarenal sodium loss. Diuretics and salt wasting would cause renal losses of sodium. Diarrhea, vomiting, and sweating would cause extrarenal sodium loss. If you want to use the fractional excretion of sodium, because you're unsure if the patient is hypovolemic or euvolemic, use fractional excretion of sodium less than 0.5%, not less than 1%. Urine sodium in isolation is less informative and may not be appropriate because of urine volume and muscle mass. Salt wasting nephropathies include cerebral salt wasting syndrome. Cerebral salt wasting syndrome is a form of Fanconi syndrome, and this occurs at the level of the proximal tubule. Bartter syndrome occurs at the level of the thick ascending limb of the loop of Henle. Kittelman syndrome occurs at the level of the distal convoluted tubule. Congenital adrenal hyperplasia and pseudohypoaldosteronism type 1 occur at the level of the cortical collecting duct. These will be discussed either in different sessions of the 8 sessions of board review or in individual sessions following the board review sessions, depending on viewer suggestions and viewer preferences. Let's talk about the treatment of hypotonic hypovolemic hyponatremia. First, one has to determine how much fluid, typically normal saline, needs to be provided. In order to control the rate of correction, adhere to 24-hour goals of correction, avoid overcorrection, which means avoiding excessive fluid shifts in the brain to avoid adverse neurological events. To do that, one has to calculate the sodium deficit, which is the desired change in serum sodium times the weight in kilograms times 0.6 if it's a male patient or 0.5 if it's a female patient. For example, in a 50 kilogram male in whom a change of 8 milliequivalents is desired, the sodium deficit is 8 times 50 times 0.6, which is 240 millimoles. 1 liter of normal saline has 150 millimoles of sodium. So 1600 milliliters of normal saline is needed to be provided over 24 hours, which would determine a rate of 67 milliliters per hour. Of course, reality is always different than theory. You may overcorrect or undercorrect. So check serum sodium levels frequently and adjust the rate of fluids to achieve the desired rate of correction. Let's talk about hypotonic hypervolemic hyponatremia. This is usually congestive heart failure, nephrotic syndrome, or liver cirrhosis. Liver cirrhosis will be discussed in the slides that are coming up. Congestive heart failure and nephrotic syndrome can typically be treated with diuretics to cause water loss more than sodium loss. Patients with liver cirrhosis can be hypovolemic or hypervolemic, just like any other patient. However, hyponatremia in liver cirrhosis can be due to hepatorenal physiology, not hepatorenal syndrome. Hepatorenal syndrome implies acute kidney injury. However, even if the patient does not have acute kidney injury, the patient still can have hepatorenal physiology and does have hepatorenal physiology, and that can result in hyponatremia, and the treatment is to avoid excessive hypotension and provide intravenous albumin, octreotide, and midodrine. Hepatorenal physiology should be considered once treatment of the hypovolemic and hypervolemic etiologies has failed. Urine output is typically low, and fluid consumption should be less than the urine output, but this is very difficult, so a 1 liter fluid restriction per day is usually implemented. Diuretic use can be a double-edged sword since it can cause hypotension. Holding diuretics initially is usually appropriate. Hypotonic euvolemic hyponatremia implies lack of external volume excess, such as lower extremity edema and pulmonary edema. Total body water is still in excess of total body sodium. Euvolemic hyponatremia is a condition of ADH excess. ADH excess can be idiopathic. Idiopathic excess of ADH is called syndrome of inappropriate antidiuretic hormone, or SIADH. There are secondary causes of ADH release, such as pain, nausea, pneumonia, and malignancy. These are non-osmotic causes of ADH excess. Treatment should begin with fluid restriction. Diuretics and sodium chloride tablets can be used as a means of excreting excess free water. Soft tablets cause resolution of hyponatremia by increasing free water excretion. Tolvaptan is an option, but it is generally avoidable due to inability to control rate of sodium correction. The only exception may be if the urine osmolality is greater than 600 milliosmoles per kilogram. When do you use hypertonic saline? If the hyponatremia is severe and correction of hyponatremia needs to be slow, controlled, and within strict 24-hour goals, 3% saline is appropriate. If the urine osmolality is greater than 600 milliosmoles per kilogram, 3% saline is typically appropriate or necessary. You begin with calculating the sodium deficit, which is the desired change in serum sodium times the weight in kilogram, times 0.6 for males or 0.5 for females. So for example, in a 50 kilogram male in whom a change of 8 milliequivalents is desired, the sodium deficit is 8 times 50 times 0.6, which is 240 millimoles. 1 liter of 3% saline has approximately 500 millimoles. So 480 milliliters of 3% saline needs to be provided over 24 hours, which is a rate of 20 milliliters per hour. Again, reality is always different than theory, and so check serum sodium levels frequently and adjust the rate of fluids to achieve the desired rate of correction. Tolvaptan counteracts the actions of vasopressin by blocking the V2 receptor, thereby decreasing the expression of the aquaporin channels. Tolvaptan effectively causes free water loss. However, one is unable to control the rate of sodium correction. If tolvaptan is used, patients should be advised to drink to thirst. Tolvaptan is only approved for euvolemic and hypervolemic hyponatremia. Duration is very important. Acute hyponatremia is defined as less than 24 hours. Acute hyponatremia can be corrected rapidly. The most common acute hyponatremia occurs after a marathon, and we will discuss marathon runner hyponatremia in detail in the upcoming slides. However, most hyponatremia is chronic. If duration is unknown or uncertain, assume that it's chronic hyponatremia. Chronic hyponatremia should be corrected slowly, 8 milliequivalents over 24 hours. If the hyponatremia is symptomatic, this is considered a medical emergency. Symptoms can be severe, such as seizures, obtundation, coma, or respiratory arrest, or they may be less severe, such as headaches, nausea, vomiting, tremors, gait, movement disturbances, or confusion. Regardless of whether the symptoms are severe or less severe, symptomatic hyponatremia is a medical emergency. Initial treatment should be hypertonic saline. The goal of therapy is to rapidly increase the serum sodium by 4 to 6 milliequivalents per liter over a period of a few hours. Raising the serum sodium by 4 to 6 milliequivalents per liter should generally alleviate symptoms and prevent herniation. However, rate of correction should not exceed 2 millimoles per liter per hour. Treatment is with a 100 milliliter bolus of 3% saline, followed, if symptoms persist, with up to 2 additional 100 milliliter doses to a total dose of 300 milliliters. Each bolus is infused over 10 minutes. Frequently, marathon runners will come to you and ask you how much water they should drink during a marathon. These are the guidelines. Do practice runs, weigh yourself every hour, drink 16 ounces for every 1 pound weight loss, or drink 400 to 800 milliliters per hour. That's 14 to 27 fluid ounces per hour. Don't force fluid consumption. Avoid NSAIDs. Drink less if stomach becomes queasy or sloshy. Drink sports drinks, although it's not proven that they're better than water. Don't drink immediately after a marathon. Risk factors for hyponatremia are weight gain, run greater than 4 hours, and small or large body mass index. Marathon runner hyponatremia should be corrected rapidly with 3% saline. We will take questions intermittently to stimulate our thinking. Which one of the following is most likely to be associated with the development of hyponatremia in individuals involved in heavy exercise? Urine sodium plus urine potassium equal to 36 milliequivalents per liter, urine osmolality of 200 milliosmoles per kilogram after exercise, weight gain greater than 3 kilograms after exercise, and increase in urine osmolality during exercise. Relevant factors in marathon runners include pain, nausea, and stress. These are non-osmotic factors that cause ADH release. But the most important factor is excessive fluid intake. Excessive exercise-associated hyponatremia is primarily due to water gain and secondarily due to sodium chloride loss. The majority of individuals who develop exercise-associated hyponatremia gain weight during exercise as a result of excessive water intake and retention. While urinary indices would shed light on the mechanism of water gain, for example, a high urine osmolality would indicate a high ADH state that's usually observed in these individuals, the final outcome is due to net water gain that is reflected in an increase in weight. A 25-year-old woman marathon runner becomes confused after completing the run in 5 hours and 15 minutes. Her serum sodium at the end of the run is 125 milliequivalents per liter. On physical examination, she is obtunded. The blood pressure is 140 over 80 millimeters of mercury and the pulse rate is 86 per minute. Skin turgor is normal. The remainder of the examination is normal. Which one of the following is most important in the pathogenesis of our hyponatremia? Excessive water intake and retention, sequestration of water in the gastrointestinal tract, sodium chloride loss in sweat, decreased extracellular fluid volume. The patient is obtunded, so remember that symptoms are the most important, even if the magnitude of hyponatremia is not that great. Excessive water intake and retention of ingested fluid are the most important factors in the pathogenesis of exercise-induced hyponatremia. Exercise-induced hyponatremia is more common in individuals with a low body mass index who require a longer amount of time to complete the race. Such individuals are more likely to consume proportionately larger volumes of water during a marathon. Water may be transiently sequestered in the gastrointestinal tract in marathon runners. This may result in further decreases in the serum sodium level after completion of the race. However, it is the ingestion and retention of water that ultimately causes exercise-induced hyponatremia. Sodium chloride losses in sweat are hypotonic and cause hypernatremia. Exercise-induced hyponatremia gain weight because of water ingestion and retention. As a result, both the intracellular and extracellular fluid volumes are increased at a ratio of 2 to 1. Rapid overcorrection of hyponatremia causes a rapid change in osmolality. Oligodendrocytes are very sensitive to osmotic stress. Therefore, rapid overcorrection results in osmotic demyelination syndrome. The clinical presentation includes neurological findings such as upper motor neuron deficits, pseudobulbar palsy, spastic quadriparesis, confusion, and coma. Symptoms may not present themselves until 2 to 3 days after correction of plasma sodium. And the clinical presentation can be biphasic, with initial improvement of mental status after raising plasma sodium, followed by subsequent decline. Reversal of overcorrection is very important. The first step is to start D5W to match the urine output. If the urine output is 200 cc's per hour, start D5W at 200 cc's per hour. Indications for desmopressin include the following. Diuresis occurs at an excessive rate, that is, it's unable to be matched by D5W. 24-hour goal for change in plasma sodium has been exceeded or is predicted to do so despite D5W, and symptoms of osmotic demyelination develop. The typical dosage is desmopressin 2 micrograms IVQ 8 hours. Beer drinkers' podomania or Tito's diet should be discussed in detail. First thing to understand is that solute intake is very important in order for you to generate urine output. If you do not generate solute, you cannot generate urine output. Normal people, if we were to drink lots and lots of fluid and not eat solute, we would break down muscle and fat. And that breakdown would generate solute, and we would generate urine, and we would get rid of excess free water. Patients who drink alcohol but do not consume solute are not able to excrete free water. Alcohol is basically fluid with a few calories, so muscle or fat breakdown does not occur. ADH is massively suppressed due to poor solute intake and excessive fluid consumption. In these cases, solute intake or normal saline can cause marked polyuria and rapid overcorrection. How do you prevent osmotic demyelination in beer drinkers' podomania or high-risk patients? Keep them NPO except medications for 24 hours. Avoid intravenous saline if possible. Check plasma sodium every 2 hours. The goals are to increase plasma sodium less than 8 millimoles per liter in the first 24 hours and any subsequent 24-hour period. You must avoid overcorrection. Relower plasma sodium levels if necessary. If caloric intake is needed, use D5W. Let's talk about the differential for hypotonic hyponatremia. Like we discussed, you can break it down into hypovolemic, euvolemic, or hypervolemic hyponatremia. You can see that almost always the urine osmolality is greater than plasma osmolality, except it's less than plasma osmolality in recent osmostat, psychogenic polydipsia, or beer drinkers' potomania. The fact that urine osmolality is greater than plasma osmolality indicates the presence of ADH. If the patient is hypovolemic and the fractional excretion of sodium is less than 1, it's generally gastrointestinal or sweat loss. If the fractional excretion of greater than 1 and the patient is hypovolemic, consider salt-losing nephropathy, adrenal insufficiency, isolated mineral, corticoid insufficiency, or diuretics. If the patient is euvolemic, of course, syndrome of inappropriate antidiuretic hormone. If it's idiopathic, sometimes it can be NSID, which is nephrogenic syndrome of inappropriate antidiuresis. These are activating mutations in the ABPR2 gene, which result in fluid retention and hyponatremia. Reset osmostat basically means that the threshold for ADH release is altered and the serum sodium level is maintained at a lower level. Reset osmostat frequently does not respond to treatment, and the lack of correction of hyponatremia, despite the measures that are used in the treatment of SI-ADH, usually mean that it's reset osmostat and that the hyponatremia is chronic and that correction may not be appropriate. Psychogenic polydipsia indicates that the patient is drinking gallons and gallons of water and the urine osmolality is less than plasma osmolality. Beer drinkers' potomania we talked about. Other euvolemic causes include exercise-induced hyponatremia, post-operative hyponatremia, medications such as antidepressants, and hypothyroidism. Hypervolemic hyponatremia. If the fractional excretion of sodium is less than 1, consider congestive heart failure, cirrhosis, or nephrotic syndrome. If the fractional excretion of sodium is greater than 1, generally occurs in renal failure. Let's move on to hypernatremia. Hypernatremia is always a hypertonic situation. Most of the time, it's due to impaired thirst, lack of access to water, or inability to ask for water. The treatment is to calculate the free water deficit, add approximate urinary and insensible losses, and replace the total free water loss over 24 hours, or extend it to 48 hours if there is marked congestive heart failure, senility, etc. Uncommonly, hypernatremia can be due to polyuria, as in central diabetes insipidus, nephrogenic diabetes insipidus. Polyuria can also be due to solute diuresis. Solute diuresis will be discussed in an individual session after the 8 sessions of board review. Central diabetes insipidus occurs in the setting of trauma, brain injury, space-occupying lesions, infections, mutations in the AVP gene, and idiopathic tumor. Nephrogenic diabetes insipidus can be congenital, can occur in the setting of some drugs such as lithium, hypercalcemia, and tubular disease. If you have polyuria, then you should break it down into water diuresis, solute diuresis, or mixed water plus solute diuresis. The way to do that is by looking at the urine osmolality. If the urine osmolality is less than 150 milliosmoles per kilogram, it's a pure water diuresis. If the urine osmolality is greater than 300 milliosmoles per kilogram, it's a pure solute diuresis. And if it's between 150 to 300 milliosmoles per kilogram, it's generally a mixed water diuresis plus solute diuresis. If you've established that it's a water diuresis and you have hyponatremia, serum sodium less than 135 millimoles per liter, that's consistent with primary polydipsia. And if you've established water diuresis and you have hypernatremia with a serum sodium greater than 147, that's generally diabetes insipidus. If the serum sodium level is within normal limits, then you should do a water deprivation test to distinguish between primary polydipsia, central diabetes insipidus, or nephrogenic diabetes insipidus. So how do you do the water restriction test? Access to water is stopped. Every hour, patients are weighed and urine and blood samples are collected for the determination of plasma and urine sodium, potassium and osmolality, and plasma AVP. Water deprivation is discontinued when one of the following criteria is met. A urine osmolality of at least 800 milliosmoles per kilogram. This is considered diagnostic of psychogenic polydipsia. Weight loss of more than 5% from baseline, or plasma osmolality exceeding 300 milliosmoles per kilogram. This is considered diagnostic of diabetes insipidus. If the patient is known to have a pituitary disorder, central diabetes insipidus is likely. If the subject used lithium, then nephrogenic diabetes insipidus is most probable. If the subject neither had pituitary disease nor used lithium, differentiation between central diabetes insipidus and nephrogenic diabetes insipidus can be made according to the response to desmopressin. The desmopressin phase of the water restriction test can be initiated if either one of the following endpoints are achieved. The dehydration phase is completed for 8 hours, except in those who need longer periods of dehydration. 2 consecutive urine osmolality measures do not differ by 10% or more, and loss of 2% body weight. Premature termination of the dehydration phase due to loss of more than 3% of body weight, elevation of serum sodium to above normal limits, or intractable thirst. An injection of 2 micrograms of desmopressin is administered either through the intravenous or intramuscular route, and plasma and urine sodium, serum osmolality, urine osmolality, and plasma AVP are obtained hourly for 1 to 2 hours after injection. A desmopressin administration through oral or intranasal route does not result in predictable absorption, and typically an accurate diagnosis is crucial. Therefore, oral or intranasal desmopressin administration is not recommended. During the desmopressin phase, the patient can eat and drink, even up to 1.5 to 2 times the volume of urine passed during the dehydration phase. The normal response to the water restriction test is the one shown in red. The urine osmolality improves markedly during the dehydration phase, maximally, and does not improve any further with administration of desmopressin. In complete diabetes insipidus, the urine osmolality does not improve during the dehydration phase. Once desmopressin is administered, the urine osmolality improves markedly. In partial central diabetes insipidus, the urine osmolality improves a little bit during the dehydration phase, and then once the desmopressin is administered, the urine osmolality improves even more. In complete nephrogenic diabetes insipidus, the urine osmolality does not improve during the dehydration phase and does not improve with desmopressin. In partial diabetes, nephrogenic diabetes insipidus, the urine osmolality improves during the dehydration phase and does not improve with desmopressin. In primary polydipsia, the urine osmolality does improve in the dehydration phase, but does not improve with desmopressin. In nephrogenic diabetes insipidus, plasma ABP is high, and there will be little or no response to DDABP. In CDI, central diabetes insipidus, plasma ABP is low, and there will be a marked response to DDABP. The plasma ABP level may not come back immediately because it's usually a send-out test. Copeptin is the C-terminal part of the ABP precursor. Copeptin levels in the serum reflect the concentration of ABP in circulation, making it a stable and sensitive marker for ABP release. Copeptin is a send-out test and takes time to come back, but it should be sent because it can be insightful in the days after the water restriction test. A baseline copeptin level greater than 21.4 picomoles per liter is diagnostic of nephrogenic diabetes insipidus. However, it may take long to come back as it is a send-out lab. In central diabetes insipidus, exogenous DDABP must be administered. Various formulations are available, including intranasal. Nephrogenic diabetes insipidus can be treated with D5W. Patients with nephrogenic diabetes insipidus can usually push oral free water for maintenance. For example, if a patient makes 6 liters of urine, he or she must drink 6 liters of water. Time for a question. A 53-year-old man is admitted to the intensive care unit with urosepsis. His sodium level has risen slowly from 140 to 155 milliequivalents per liter over the past 5 days. He is lethargic but responds appropriately to simple questions. His blood pressure is 130/70 millimeters of mercury off of vasopressor agents. The pulse rate is 80 per minute. His weight is 60 kilograms. The remainder of the examination is unremarkable. His current urine output is 2 liters per day. Laboratory studies show serum osmolality of 329 milliosmoles per kilogram, sodium of 155 milliequivalents per liter, potassium of 3.6 milliequivalents per liter, chloride of 122 milliequivalents per liter, total bicarb of 20 millimoles per liter, BUN of 36 milligrams per deciliter, creatinine of 1.5 milligrams per deciliter, and glucose of 88 milligrams per deciliter. Urinary studies show sodium of 60 milliequivalents per liter, potassium of 40 milliequivalents per liter, and osmolality of 315 milliosmoles per kilogram. Assuming insensible water losses of 0.8 liters per day, which one of the following is the total amount of free water that should be administered to decrease the serum sodium to 145 milliequivalents per liter over the next 24 hours? 4 liters, 3.2 liters, 2.3 liters, or 1.6 liters. free water deficit is 2.5 liters. You can calculate this with various online calculators. The equation for the free water deficit is available easily in all sources and can be learned. A quick approximation of urine loss is around half of the urine output. So the electrolyte-free water clearance, urinary water clearance, can be calculated, but it does require additional information and it requires time and effort. A quick approximation would be to assume that about half of the urine output is electrolyte-free urine loss. So in this case, around 1 liter. Insensible losses have been specified at around 0.8 liters. So half of this would be 0.4 liters. And the total free water deficit, therefore, is 2.5 plus 1 plus 0.4, which is approximately 3.9 liters. So the correct answer is option A. Let's move on to potassium. Potassium is mostly intracellular. The way to remember this is pint, potassium intracellular, pint. Sodium is mostly extracellular. Frequently, it's very important to understand the factors that play a role in potassium secretion or potassium excretion. The most important to remember of these would be aldosterone, Maxi-K channels, which respond to urine flow, distal sodium delivery. Of course, other factors are important and usually are obvious, like sodium and potassium intake. Magnesium is very important because you cannot correct hypokalemia until you have corrected hypomagnesemia. And the reason is that the presence of magnesium blocks potassium secretion. This is the luminal aspect of the tubule, and magnesium blocks secretion of potassium into the lumen, blocking potassium loss. Mineralocorticoids, of course, play a role. Non-chloride anions such as bicarb and hippurates are important. Non-chloride anions such as bicarb will cause obligate potassium losses because potassium will follow bicarb as it's lost in the urine. So bicarbonaturia will cause potassium losses in the urine. Compartment shifts are important, such as acute acid-base aberrations, insulin, and catecholamines. Alpha agonists increase plasma potassium. Beta agonists decrease plasma potassium. Lupin thiazide diuretics, of course, are important, and potassium-sparing diuretics should be noted whenever potassium aberrations are being treated. Let's discuss potassium secretion. Potassium is secreted by the late distal convoluted tubule, connecting segment, and cortical and outer medullary collecting tubules. This secretion depends on the potassium concentration gradient across the luminal membrane of principal cells, which is determined by the difference between cell and urine potassium concentrations. We're going to discuss the potassium concentration gradient in detail, especially as we discuss the transtubular potassium gradient. Aldosterone and high plasma potassium concentration promote potassium secretion. Other important determinants are potassium permeability of the luminal membrane through potassium channels, sodium delivery, urine flow rate into the distal nephron, and the degree of electronegativity of the urinary lumen generated by sodium reabsorption through luminal sodium channels and the anion composition of the urine. The urine to plasma potassium concentration ratio measures the gradient for potassium secretion. And we just mentioned that the potassium concentration gradient is important for potassium secretion. So the urine potassium to plasma potassium ratio measures or takes into account the potassium gradient across the lumen. The urine to plasma osmolality ratio adjusts for the degree of medullary water reabsorption, which increases the urine potassium concentration as more water is absorbed. One premise underlying the transtubular potassium gradient calculation is the absence of significant solute transport in the medullary collecting duct, such that any change in the urinary potassium concentration that occurs after exit from the cortex derives only from water reabsorption. So the assumption in the transtubular potassium gradient is that in the medullary collecting duct, the only thing that's happening is that water is being reabsorbed. And as the water is reabsorbed, the potassium concentration changes, and as the potassium concentration changes, the potassium gradient changes. Therefore, the transtubular potassium gradient accounts for the urine to plasma potassium concentration ratio and the urine to plasma osmolality ratio. Subsequently, it was shown that urea is reabsorbed from the medullary collecting duct, resulting in decreased urine osmolality. Thus, the transtubular potassium gradient would overestimate the gradient for cortical collecting duct potassium secretion. As you can see, water is reabsorbed in the collecting duct, and in the medullary collecting duct, urea is also reabsorbed. Therefore, reabsorption of urea would alter the potassium concentration, and therefore the transtubular potassium gradient would overestimate the gradient for cortical collecting duct potassium secretion. Also, in situations with a dilute urine or high urine flow rate, the transtubular potassium gradient underestimates potassium secretory capacity in the hyperkalemic patient. Other things to remember is that calculation of the transtubular potassium gradient requires that urine sodium be 25 milliequivalents per liter, so that sodium delivery to potassium cells is not rate limiting for potassium secretion. This value is twice the concentration required for half maximal rates of potassium secretion in the right distal nephron. Another prerequisite for calculating the transtubular potassium gradient is that urine osmolality be equal to or greater than plasma osmolality, because vasopressin is required for optimal potassium excretion in the distal cortical nephron. So largely because the assumption of the transtubular potassium gradient that significant solute reabsorption is not occurring in the medullary collecting duct, because that assumption is not true, the transtubular potassium gradient has lost its favor and is no longer being clinically used and may not be tested upon on the boards. Urine potassium in isolation is unreliable, just like the urine sodium, as we discussed, is unreliable in isolation. The urine potassium to creatinine ratio has been well studied in hypokalemia. The urine potassium to creatinine ratio greater than 22 millimoles per gram indicates loss of potassium. Losses of potassium. Urine potassium to creatinine ratio less than 22 millimoles per gram is consistent with renal conservation of potassium, which occurs with poor oral intake or extrarenal loss of potassium. Note that the urine potassium to creatinine ratio is in units of millimoles per gram. Urine potassium is reported in millimoles per liter. Urine creatinine is reported in milligrams per deciliter. So you cannot just divide urine potassium by urine creatinine. You must correct the units by multiplying by 100 to end up in units of millimoles per gram. 24-hour urine is usually impractical and not necessary. Let's just discuss the reference ranges for renin-aldosterone. As we will discuss in the next few slides, renin and aldosterone, if the levels are available, can be important in dissecting the differential diagnosis of hypokalemia as well as hyperkalemia. The reference range for renin is 0.6 to 3.0 nanogram per milliliter per hour. Low renin is defined as 0.6 to 1.0 nanogram per milliliter per hour. Reference range for aldosterone is 2 to 5 nanogram per deciliter. Renin and aldo levels above reference range can be considered high. This is the differential for hypokalemia. If the urine potassium to creatinine ratio is greater than 22 millimoles per gram, this would be consistent with the renal losses of potassium. If you have the renin-aldo levels, that can help you dissect the differential. A high renin, high aldo scenario indicates secondary aldosteronism and can be present in malignant hypertension, renin-secreting tumor, pheochromocytoma, renovascular hypertension, vomiting, Bartter syndrome, Gittleman syndrome, or diuretics. Low renin, high aldo is consistent with primary aldosteronism, glucocorticoid remediable hyperaldosteronism, and low renin hypertension. Low renin, low aldo scenarios include congenital adrenal hyperplasia, apparent mineralocorticoid excess, licorice ingestion, Liddle syndrome, Cushing syndrome, and exogenous steroids use. In proximal or distal renal tubular acidosis, the renin and aldo can be variable. Discussion of some or all of these topics can be found in other sessions of board review or in individual sessions to follow after the 8 sessions of board review and may be dependent upon your preferences. If the urine potassium to creatinine ratio is less than 22 millimoles per gram, this would be consistent with poor oral intake or extrarenal loss. Typically in this situation, the renin-aldo can be variable, and the clinical scenario that is usually relevant would be such as diarrhea, laxatives, low potassium diet, or increased cellular potassium uptake, as in with insulin, bicarbonate, or periodic paralysis. What are the consequences of hypokalemia? On the EKG, you may see U waves, which typically follow the T waves. Neuromuscular effects include weakness, rhabdomyolysis, ileus, encephalopathy, typically in liver cirrhosis, muscle cramps, and tetany. Metabolic and hormonal effects include decreased insulin release, decreased peripheral effect of insulin, negative nitrogen balance, and inhibition of aldosterone release. Renal effects include nephrogenic diabetes insipidus, which is characterized by polyuria and polydipsia, and increased renal ammonia production with resultant encephalopathy. How do you treat hypokalemia? One pearl is that you must correct hypomagnesemia, because if you do not correct hypomagnesemia, correction of hypokalemia becomes very difficult and maybe impossible. One way to determine appropriate potassium supplementation is to calculate the potassium deficit, which is the desired change in serum potassium, which is 3.5 minus the measured serum potassium, times 0.4 times the weight in kilograms. For example, in a 50 kilograms patient with serum potassium of 3.0, the potassium deficit would be 0.5 times 0.4 times 50, which is 10 milliequivalents. Then you must add 0.5 milliequivalents per kilogram if the patient is eating, or 1 milliequivalent per kilogram if the patient is not eating or is on high-dose diuretics. So in our example, if the patient was eating, the total potassium deficit would be 10 milliequivalents plus 25 milliequivalents, which is 35 milliequivalents. Finally, you must take into account the glomerular filtration rate. If the GFR is less than 30 milliliters per minute per body surface area, provide only half of the total potassium deficit. Recheck serum potassium and provide additional supplementation if serum potassium remains below goal. Let's talk about Barter's syndrome and Gitelman's syndrome. Barter's syndrome is a renal tubular salt wasting disorder involving the sodium potassium chloride cotransporter in the thick ascending limb of the loop of Henle. This leads to activation of the renin-angiotensin-aldosterone system and subsequent secondary hyperaldosteronism. The defective sodium chloride transport leads to an impaired electrochemical gradient, which is necessary for calcium and magnesium reabsorption, leading to increased urinary loss of calcium and magnesium. Gitelman's syndrome is an autosomal recessive salt-losing tubulopathy characterized by renal potassium wasting, hypokalemia, metabolic alkalosis, hypocalciuria, hypomagnesemia, and hyperenanemic hyperaldosteronism. Gitelman's syndrome involves the sodium chloride cotransporter and a magnesium channel in the distal convoluted tubule. Barter's syndrome can be acquired, such as in aminoglycosides. Gitelman's syndrome can be acquired, such as in cisplatin, Sjogren's syndrome, or other autoimmune diseases. Treatment is with oral potassium and magnesium supplementation. Intravenous magnesium can be used if there is tetany. Typically, intravenous potassium or intravenous magnesium supplementation should not be used in Barter's syndrome and Gitelman's syndrome because the potassium and magnesium will be wasted in the urine, and it'll be very difficult to correct with intravenous potassium and magnesium, and the patient will have to go to the outpatient infusion center frequently, and there will be a lot of waste of resources, and it will be difficult for the patient to comply with visits to the outpatient infusion center, and it will be time consuming. Oral potassium and magnesium supplementation is effective and appropriate. Push oral fluids. If tolerated, consider aldosterone antagonists, potassium-sparing diuretics like amiloride and spironolactone, as well as inhibitors of the renin-angiotensin system. However, these agents may not be well tolerated in patients with low blood pressure and should be administered with caution. Time for a question. A 20-year-old woman is referred for hypokalemic metabolic alkalosis. Over the past several years, she has noted progressive worsening of polyuria, thirst, salt craving, weakness, and fatigue. She does not have vomiting and is on no medications. On physical examination, the blood pressure is 110/70 millimeters of mercury and the pulse rate is 74 per minute. The remainder of the exam is normal. Laboratory studies show sodium of 140 milligrams per liter, potassium of 2.2 milligrams per liter, chloride of 88 milligrams per liter, total bicarb of 42 millimoles per liter, BUN of 12 milligrams per deciliter, creatinine of 0.9 milligrams per deciliter, glucose of 90 milligrams per deciliter, calcium of 9.2 milligrams per deciliter, and magnesium of 1.7 milligrams per deciliter. The plasma renin activity is 102 nanogram per milliliter per hour. Plasma aldosterone is 56.5 nanogram per deciliter. Urinary electrolytes are sodium of 45 milligrams per liter, potassium of 50 milligrams per liter, and chloride of 60 milligrams per liter. The urine calcium to creatinine ratio is 280 milligrams per gram. Which one of the following is the most likely diagnosis? Primary hyperaldosteronism, Gitelman's syndrome, Barter's syndrome, surreptitious vomiting, or Little syndrome. This is the high renin, high aldo scenario. The patient is not hypertensive and the aldosterone to renin ratio is not high. So primary hyperaldosteronism is incorrect. In primary hyperaldosteronism, plasma aldosterone is greater than 15 and the plasma aldosterone to plasma renin activity should be greater than 20. In surreptitious vomiting, urine chloride should be low, so vomiting is incorrect. Also, the level of alkalemia is too high to be related to vomiting. Little's is a low renin, low aldo scenario. In Kittelman syndrome, one expects hypocalciuria. Typically, urine calcium to creatinine ratio is less than 44 milligrams per gram. Kittelman syndrome and Barter's syndrome will be discussed in other sessions of board review. Therefore, Barter's syndrome is the correct answer. The transtubular potassium gradient is no longer recommended, as we just discussed. The urine potassium to creatinine ratio has not been well studied in hyperkalemia. So what should we use to determine whether potassium secretion is adequate or inadequate for the clinical scenario? The fractional excretion of potassium may be more informative. The fractional excretion of potassium less than 10% indicates impaired renal excretion. Fractional excretion of potassium greater than 10% is consistent with increased production, intake, or compartment jets. This is the differential for hyperkalemia. If the fractional excretion of potassium is less than 10%, this indicates impaired renal excretion. Again, renin and aldo may be informative if the levels are available. A low renin, low aldo scenario would be consistent with renal tubular acidosis type 4, NSAIDs, interstitial nephritis, obstruction, and Gordon's syndrome. A high renin, low aldo scenario would be consistent with Addison's disease, primary hypoaldosteronism, congenital adrenal hyperplasia, direct renin inhibitors such as aliskiren, and medications such as ACE inhibitors, ARBs, and heparin. A high renin, high aldo scenario would include hypoaldosteronism type 1, aldosterone resistance, ENaC channel blockers such as trimethoprim, triamterene, and pentamidine, aldosterone receptor blockers such as spironolactone and eplerenone, and calcineurin inhibitors. Chronic kidney disease may be typified by a normal renin and high aldo level. If the fractional excretion of potassium is greater than 10%, this could be consistent with increased production, intake, or compartment jets. Increased production would be states such as tumor lysis, tissue necrosis, hemolysis, or rhabdo. In these situations, renin and aldo are typically high. Salt substitutes, high potassium foods, pica, intravenous penicillin, transfusions, and potassium supplements will lead to hyperkalemia because of excessive input. Hyperkalemia can be spurious, and this can occur in severe leukocytosis, severe thrombocytosis, fist clenching, or prolonged use of tourniquet. Compartment jets should be considered in scenarios such as periodic paralysis, hyperglycemia, succinylcholine, inorganic metabolic acidosis, hyperosmolality, and digoxin poisoning. So one thing to remember is that inorganic metabolic acidosis causes compartment shifts of potassium, not organic metabolic acidosis, such as lactic acidosis. So the thing to remember is that insofar as inorganic versus organic metabolic acidosis is concerned, you have the sodium potassium ATPase, you have the sodium potassium exchanger, sodium bicarb transporter, and the organic anion and proton co-transporter. So if you have metabolic acidosis, you'll have a fall in extracellular pH, and the fall in extracellular pH will inhibit the sodium proton exchange, which will then result in decreased entry of sodium into the cell. And therefore, there's reduced activity of the sodium potassium ATPase, decreased active cellular potassium uptake, and the final result would be as if protons had entered the cell in exchange for potassium. The fall in extracellular bicarb would inhibit the rate of sodium, inward rate of sodium, bicarbonate co-transport, and then the fall in intracellular sodium, reduced sodium potassium ATPase activity would result in net loss of cellular potassium. Again, the result would be as if protons had entered the cell in exchange for potassium. So essentially, what we're taught is that protons move into the cell and potassium moves into the extracellular compartment. Of course, the details of that includes several transporters, but the ultimate result is the same, as if protons had entered the cell in exchange for potassium. Why doesn't this happen in organic metabolic acidosis? The quick answer is that the organic anion will travel along with the proton. So ultimately, there is no need for electron neutrality with transport of potassium. The details are as follows. There is strong inward flux of the organic anion, such as lactate and proton, through the monocarboxylate transporter. A larger fall in intracellular pH and bicarb will stimulate sodium entry by the sodium proton exchange and sodium bicarbonate co-transport. This stimulates the sodium potassium ATPase activity. The net effect would be to drive net cellular uptake of potassium. So essentially, in inorganic metabolic acidosis, proton moves into the cell, potassium moves outward. In organic metabolic acidosis, since the organic anion and protons travel together, there is no need for potassium to maintain electron neutrality. Therefore, compartment shift of potassium does not occur. What are the consequences of hyperkalemia? On the EKG, the typical sequence of findings is as follows. The earliest finding that is detectable is the appearance of tall peaked T waves. This is followed by prolonged PR interval, which is followed by widened QRS complexes, which is followed by disappearance of P waves and a sine wave pattern. Neuromuscular effects include weakness and paralysis. Hormonal and renal effects include decreased ammonia production, leading to impaired excretion of ammonium and metabolic acidosis. Symptoms include weakness, fatigue, muscle paralysis, palpitations, bradycardia, and cardiac arrest. Treatment of hyperkalemia includes low potassium diet, discontinuation of medications that cause hyperkalemia, discontinue salt substitutes, use potassium binders judiciously, use loop diuretics or thiazide diuretics if appropriate, use mineralocorticoids if necessary. If hyperkalemia is life-threatening, then use calcium, typically calcium gluconate, to prevent triggering of arrhythmias. Use insulin and dextrose to cause compartment shifts. Sodium bicarbonate if serum bicarb is less than 22, and if necessary, renal replacement therapy. We should mention pseudohypoaldosteronism at this point. Pseudohypoaldosteronism 1 is due to a defect in ENaC channels or mineralocorticoid receptor, leading to aldosterone resistance. Renin and aldo are high. This can be autosomal dominant or autosomal recessive, and treatment consists of a high salt diet which prevents volume depletion and, by enhancing sodium delivery to the potassium secretory site in the collecting tubules, increases potassium excretion and lowers the plasma potassium concentration. High-dose fluorocortisone or carbinoxolone can be added if a high salt intake is ineffective or not well tolerated. Pseudohypoaldosteronism type 2 or familial hyperkalemic hypertension is also known as Gordon syndrome. This is characterized by mutations in the Wnt kinases, leading to upregulation of the sodium chloride cotransporter with the resultant increased sodium reabsorption, reduced expression of the renal outer medullary potassium channel, and subsequent hyperkalemia. The treatment is with thiazide diuretics that act by inhibiting the sodium chloride cotransporter. Gordon syndrome can be acquired, such as in the use of calcineurin inhibitors, and acquired Gordon syndrome can also be treated with thiazide diuretics. Time for a question. A 65-year-old man is evaluated 3 weeks after receiving a deceased donor kidney transplant. He's doing well and is asymptomatic. His medications include tacrolimus, mycophenolate mofetil, prednisone, carvedilol, dapsone, and acyclovir. On physical examination, the blood pressure is 160/94 millimeters of mercury. The allograft is non-tender and without bruit. He has trace pretibial edema. The remainder of the examination is normal. Laboratory studies show sodium of 138 millicromos per liter, potassium of 5.8 millicromos per liter, chloride of 109 millicromos per liter, total CO2 of 18 millimoles per liter, BUN of 18 milligrams per deciliter, creatinine of 1.4 milligrams per deciliter, and glucose of 108 milligrams per deciliter. A 12-hour tacrolimus trough level is 8 nanograms per milliliter. An ultrasound kidney transplant shows normal vasculature and no hypernephrosis, in addition to a low potassium diet. Which one of the following is the best management of this patient's hyperkalemia? Reduce tacrolimus to achieve trough levels of 4 to 5 nanograms per milliliter. Start with thalidomide, start fluorocortisone, start sodium bicarbonate. Hyperkalemia in the post-transplant setting is often multifactorial in etiology and may be due to reduced GFR, obstruction, or medication-related effects. The absence of hydronephrosis excludes obstruction as a potential cause, and the GFR is not sufficiently reduced in this case to account for the hyperkalemia. Medications that may contribute to hyperkalemia that are commonly used following transplantation include calcineurin inhibitors, the trimethoprim component of sulfamethoxazole trimethoprim, renin-angiotensin-aldosterone antagonists, and non-selective beta blockers. Tacrolimus is likely playing a significant role in the pathogenesis of this man's hypertension and hyperkalemia. One mechanism whereby calcineurin inhibitors induce hypertension is by increasing the abundance of phosphorylated sodium chloride cotransporters and the NCC regulatory kinases, the Wnt kinases and SPAC, resulting in a phenotype analogous to pseudohypoaldosteronism type 2, familial hyperkalemic hypertension. This is a secondary cause of pseudohypoaldosteronism, but the treatment is the same. And we'll talk about pseudohypoaldosteronism in detail in an individual session after the initial 8 sessions of board review. The resultant increased activity of the sodium chloride cotransporter causes volume expansion and salt-sensitive hypertension. In addition, alterations in the Wnt kinases and SPAC decrease the expression of renal outramedullary potassium channels in principal cells in the aldosterone-sensitive portion of the distal tubule and collecting duct, causing decreased renal potassium excretion and hyperkalemia. Thiazide diuretics have been shown to reverse these effects. Therefore, addition of chlorothalidone is the best management strategy to address this man's hyperkalemia and hypertension. The tacrolimus level is appropriate for this patient who recently underwent kidney transplantation. Furthermore, a slight dose reduction is unlikely to significantly impact the hypertension and hyperkalemia. Fludrocortisone has been shown to improve post-transplant hyperkalemia. However, it may worsen sodium retention and would not be the best approach for this patient with concurrent hypertension. Sodium bicarbonate therapy would help correct metabolic acidosis and potentially augment potassium excretion in the collecting duct by enhancing lumen electronegativity. However, it could potentially worsen this man's hypervolemia and salt-sensitive hypertension. Therefore, its use in this patient should be combined with diuretic therapy if such therapy is contemplated. A 25-year-old man with a history of type 1 diabetes mellitus is admitted for management of persistent diarrhea and weakness 3 months after undergoing living-related kidney transplantation. Admission and laboratory studies disclosed significant hyperkalemia with a serum potassium level of 6.5 milligrams per liter. His medications include insulin, aspart, tacrolimus, mycophenolate mofetil, trimethoprim, sulfamethoxazole at 400 over 80 milligrams 3 times weekly, Valgen, cyclovir, and metoprolol. On physical examination, he appears fatigued, but he's alert and oriented. The blood pressure is 130 over 64 millimeters of mercury supine and 96 over 50 millimeters of mercury standing. The pulse rate increases from 80 per minute supine to 110 per minute standing. The abdominal examination shows normal bowel sounds and no peritoneal signs. The allograft is non-tender and does not have a buoy. There is no edema. Laboratory studies show sodium of 142 milligrams per liter, potassium of 6.5 milligrams per liter, chloride of 115 milligrams per liter, total bicarb of 18 millimoles per liter, BUN of 40 milligrams per deciliter, creatinine of 1.4 milligrams per deciliter, increased from 1.2 milligrams per deciliter 1 week ago, glucose of 270 milligrams per deciliter, creatinine kinase of 31 units per liter, leukocyte count of 8,000 per microliter, hemoglobin of 9.2 grams per deciliter, and platelet count of 119,000 per microliter. An arterial blood test shows pH 7.32, PCO2 of 32 millimeters of mercury, and bicarbonate of 18 milligrams per liter. The tacrolimus trough is increased at 12 nanograms per milliliter. The urinalysis shows specific gravity of 1.015, 1 plus glucose, no protein, no blood, no ketones. An electrocardiogram shows peak T waves and a prolonged PR interval. A renal transplant ultrasound is normal, in addition to therapy with intravenous insulin and calcium. Which one of the following is the next best step in the management of this man's hyperkalemia? Fludrocortisone, Potassium, isotonic sodium bicarbonate infusion, hemodialysis. This patient is clearly orthostatic from persistent diarrhea. Hyperkalemia is likely from decreased urine flow. T waves are peaked, so insulin is appropriate to cause compartment shift of potassium into the cells. Calcium will increase the neuronal activation threshold and will protect from arrhythmias. So the threshold for neuronal activation is increased, so arrhythmias cannot be activated as easily. The next best step would be to start a bicarbonate infusion to correct the orthostatic hypotension, improve the acid-base disorder, increase the urine flow to stimulate MaxiK channels to excrete potassium. Potassium binders would also be used in the real-life setting and will be discussed in the next slide. The reason you would not use Potassium is because the effect of Potassium would be delayed, and we'll talk about that in the next slide. In real life, when we do all of these things simultaneously. Hypovolemia may contribute to the pathogenesis of hyperkalemia through several mechanisms. It decreases the availability of sodium for electrogenic reabsorption via the ENaC channels in the cortical collecting duct. It decreases the volume of tubular fluid available for potassium secretion. It limits flow-mediated activation of the stretch-activated MaxiK or big potassium channels on the apical surface of principal and alpha intercalated cells. Potassium binders. So KX-late is the oldest known potassium binder. It should be avoided in patients with a history of hypersensitivity to polystyrene sulfonate resins, obstructive bowel disease, and ileus because of the risk of bowel necrosis. Potassium or Veltassa should not be used alone in the emergency treatment of life-threatening hyperkalemia because of its delayed onset of action. Potassium binds and removes potassium primarily in the colon. In one study, potassium decreased the serum potassium by 0.23 milliequivalents per liter after 7 hours. It's appropriate for use in the outpatient setting. Zirconium cyclosilicate or Lokelma binds potassium in both the small and large intestines. For patients receiving zirconium, the onset of action was at 1 hour and the median time to achieving normal potassium levels in the blood was 2.2 hours. Zirconium cyclosilicate or Lokelma can be used in the emergency room and in the outpatient setting. Both Potassium and zirconium are effective in the outpatient setting. KX-late use is limited due to its inability to be used in settings of obstructive bowel disease and ileus. Although KX-late can be given via the rectal route, so in patients who are unable to take medications by mouth, rectal KX-late can be used. That's the end of this talk. Please like and subscribe. Comments, suggestions, and questions are welcome and appreciated. See you next time.